Hi there, this is Dr. Nick Tulo. Welcome to my Saturday morning clinical live stream. I see a few people are watching and it's really a thrill. I'm glad to be here, and as a cardiac electrophysiologist, I deal with complex arrhythmias all the time. And the purpose of these live streams is to try to bring my expertise to you and see if I can get people to understand arrhythmias like I do from a physiologic standpoint. So if you enjoy this content, please subscribe to my YouTube channel, ECG Doc. And if you want additional information, I have a whole entire online ECG course at ECG Academy. That's ecgacademy.com. So anyway, let's get to the topic of today, and it's supraventricular tachycardia. It's people think they know what supraventricular tachycardia is, but when you look at an ECG, it's easy to diagnose something that's regular and narrow complex, and you'd look at it and say, oh, well, that's SVT. And someone would say, well, maybe it's PAT, or what's the difference between SVT and PSVT? And I wanted to try to put things into perspective and give you a better idea of what you should be looking for. Because it turns out that what we think of as SVT, or rapid regular arrhythmia tachycardia coming from the top chamber, actually includes several different arrhythmias, very different arrhythmias. So let's get to the case presentation here. So I'm at my laptop and I'm going to be drawing some things. So the patient actually came to one of my partners. She had a history of palpitations. She says that when she exercises, she feels her heart racing, and there was no chest pain or shortness of breath involved, maybe sometimes a little bit of lightheadedness. So the woman is in her 40s, and she's not really on any significant medical therapy. She doesn't have any hypertension or diabetes. And so my partner decided to put her on a treadmill and see what happens. And I'm going to show you that right now. So this is a recording from the stress test, and when you look at this recording, what you see is it's like a rhythm strip with a bunch of ECG leads on the left side, and it seems like there's a regular rhythm on the left-hand side with a P wave in front of each beat, and a rate that's about 125 beats a minute. So this is during a stress test. Obviously, the patient is exercising. So you have a sinus tachycardia, but then suddenly what you see is this very rapid burst of some kind of supraventricular arrhythmia. And I say it's supraventricular because the QRS complexes look very, very similar to the normal QRSs. It's not like they're arising from the ventricles, right? So you have this rapid burst of 6 or 8 beats. And when you look to see how does it start, it clearly starts with a P wave, okay? And how do I know that? Well, the trick is to look at the prior STT wave and compare it with the STT wave just before the first beat of the tachycardia. So this is beat number 1. And what you see is this very tall, spiky signal that causes the T wave to be much taller than the previous T wave. So you can see all the T's are kind of flat, and then you've got this big giant bump on the T, and that's obviously the premature atrial contraction, the PAC, that started this beginning part of this event. And so it clearly started from the atrium. There's no doubt that this is some kind of atrial rapid arrhythmia. But then what happens is the heart rate comes down a little bit to about 160 or 170 beats per minute, but it's very regular, it's narrow, it's not as fast as those first few beats, but it's obviously much faster than the sinus tachycardia before. So my partner looked at this and said, oh, it looks like PSVT. Now, when you think about PSVT, there are a couple of things that you should kind of think about when you're trying to diagnose or categorize SVT. Don't think of it all the same. You know, that's a lot of cardiologists look at them as the same, but electrophysiologists realize that SVTs come in different flavors. So the usual PSVT, or paroxysmal supraventricular tachycardia, that people see, it starts suddenly, generally stops suddenly, it's very regular, and the QRSs look like they're normally conducted. So now, what kinds of things can cause that? What sorts of electrical disturbances can cause that? Well, let's kind of think about this. Go back to my tracing here. And you have to think of PSVT as a couple of different different issues in the different major categories. So let me make some room on this tracing here. I'm going to just draw a big box in here so I can draw on it. And so if you think about SVT as being a rapid arrhythmia, hold on a second, let's pick a color. Sorry about that. So you think about SVT as being a rapid arrhythmia. There are supraventricular arrhythmias, including atrial flutter and fibrillation, that don't really fit neatly, although they're both coming from above the ventricles, right? Atrial fib and atrial flutter are coming from the atria. They're coming from above the ventricles. So in theory, these two arrhythmias are sort of a supraventricular tachyarrhythmia, but those are clearly easy to recognize. The atrial rate is 220 or plus beats per minute, usually 250 to 300. In atrial flutter, you have very discrete flutter waves that you can map out. In atrial fibrillation, it's a disorganized, chaotic atrial rhythm. And the AV node in that case is passively conducting impulses, sometimes in a regular fashion, like with atrial flutter and 2-to-1 conduction. But in the case of atrial fibrillation, what you have is sort of a chaotic, random conduction to the ventricles, which is what gives you that irregular rhythm. But what we're really talking about is a kind of sort of paroxysmal supraventricular tachycardia that is regular and it's narrow. And the most important thing is to classify this into the AV nodal dependent or the atrial arrhythmias, where the AV node is not participating in the circuit. All right, now this is a concept that a lot of people don't get when they're just starting. So you have to figure out, is the AV node part of the circuit? Is the AV node part of the reason why the patient has tachycardia in the first place? Because the most common form of PSVT is actually AV nodal reentry tachycardia. And if you know what that is, that's fabulous. Then you're really an advanced ECG student or practicing physician. If you know what AV-NRT is, it's probably responsible for about 60% of all SVT, of PSVT. And it involves the AV node directly. And here's where the AV node can have the anterior fast pathway fibers, but you can have extensions of the AV node down near the tricuspid annulus. And what you get in AV nodal reentry tachycardia is reentry usually down the slow pathway and back up the fast pathway. And then it turns around and goes back down the slow again. So there's a lot more to it than that, but the point is that the reentry circuit that's causing the tachycardia is in fact the AV nodal complex, this kind of complicated anatomy of the AV node that we find in most people, although not everybody gets SVT from it. But the other form of AV nodal dependent PSVT is known as AV reentry tachycardia, or otherwise known as AV reciprocating tachycardia. And AVRT, it's interesting. I always try to get people to remember that there's 4 letters. So that means there's 4 structures that are participating in this tachycardia. And let me just draw my John Nagy heart here for those of you who remember my first live stream. So in AVRT, you have the AV node, which is part of the circuit that conducts down to the ventricles. The ventricles participate, and what makes AVRT occur is that you have an accessory pathway somewhere, kind of like WPW, a bundle of Kent, if you will. So there's an extra electrical connection that bridges the atria and the ventricles somewhere. It could be on the right side, as I've drawn it here, could be on the left side, could even be in the center. But the point is that the electrical signal, once it gets to the ventricle, is able to make its way up this extra pathway, back to the atrium, and then turn around and go back down the AV node. So you have this reentry pathway down the AV node to the ventricles, back up the accessory pathway to the atrium, and round she goes. Now, there are different variations of this, and I'm not going to get too bogged down with it, but just so that you know that having an accessory pathway, which is something you're generally born with, and people with WPW have, but you can have concealed accessory pathways that will cause AVRT, and that's the second most common cause of PSVT. And recognizing which is which has a lot to do with understanding when the P wave occurs and what the P wave timing is. And so there's a lot of information about that on the ECG Academy website. But what you notice is that in these 2 arrhythmias, not only do you have perfectly timed one-to-one conduction between the atria and the ventricles, and what you can sometimes see is the P wave appearing just behind the QRS complex, or sometimes you can see it right in front of the QRS complex, depending upon which way the circuit is going. But you have absolute one-to-one association between the atria and the ventricles because you have a fixed circuit that's going round and round. Not only that, you can tell AV nodal dependent arrhythmias because if you give those patients adenosine, which is a substance that's in our body and has a profound effect on the AV node, it causes the AV node to stop conducting. It causes AV block, but it only lasts about 10 seconds or so. But once you block the AV node, even for just 1 beat, these 2 arrhythmias, AV-NRT and AVRT, will break, and the patient will go right back into a normal sinus rhythm. So it's kind of the behavior of the arrhythmia, how the A's and the V's are related to each other, and also how it starts and how it stops. That gives you a lot of clues that that's it. Now, I want to give you the other possibility, and let me get rid of this ECG here. I just erased my white spot here because I didn't have an extra layer. But let me just make another layer here and do the same thing as what I did before. Just down here. Sorry that these live streams are kind of challenging. They're, unlike my chalk talks that you'll see on ECG Academy, where if I make a mistake, I go and edit it out, right? I sound pretty good on those chalk talks. I don't say and I've gotten better at doing that too since these live streams. But the point I'm making is that when it's edited, I can get all the meat and potatoes, boiled down to a very clean and organized 6 minutes. But these live streams are kind of crazy. I don't know if you've ever done one, but it's a challenge. So the other possibility when you have SVT is this atrial category. And that's where you have the rapid electrical signals originating from the atria. And so you either have a focus in the atrium somewhere, which is known as either an automatic atrial tachycardia because it's coming from one little spot and it's occurring because of abnormal automaticity of the tissue. Sometimes that automatic focus can be firing because of a little known mechanism known as triggered activity. So just real quickly, triggered activity is when you have an action potential and then you have a second depolarization that occurs immediately afterwards. And so this triggered activity seems to be due to abnormalities in the handling of calcium inside the cells. Calcium currents moving in and out of the sarcoplasmic reticulum result in these depolarizations, and that can become repetitive, and that can lead to rapid atrial arrhythmias arising from the atrium, but it's a different mechanism than the automatic atrial tachycardia, so it's known as triggered. Anyway, either way, you have one little spot that's firing rapidly, and the AV node is just sort of a passive conduit to the ventricles. That's what we call it. It's just a connection. It's not participating in the arrhythmia. So that's one type of atrial arrhythmia where the AV node is not part of the circuit, and that's either automatic atrial tachycardia, which could be triggered as well, and the other kind is the intra-atrial reentry tachycardia. Intra-atrial reentry tachycardia, where you actually have an electrical circuit that's going round and round in the top chamber someplace, and sometimes this can be due to scar. It's a little like atrial flutter, but slower, in the range of like 200 beats per minute or less even. And so there again, the AV node is conducting the impulses passively. It's not participating in the circuit, but the difference is in the automatic atrial tachycardia, you have one little spot that's firing, which is known as a focus, whereas intra-atrial reentry is actually a circuit where the signal is chasing itself around and around. It even gets more complicated than that, but for the most part, these are the two categories that we consider. And I see a few people have actually been leaving some comments, and I appreciate that. I see someone's actually enjoying the participation. I appreciate that. So at any rate, thank you for watching. And if anybody has any questions, that's the beauty of these live streams, is that I can glance over and maybe answer a question for you. All right, so which is it? What do we have here? In this arrhythmia, in this person who's on the treadmill, it looks very narrow, it looks very regular, and I don't really see any visible P waves. And so the assumption is that this might actually be the AV nodal reentry tachycardia. And the reason I say that is when you don't see visible P waves, it's possible that the P wave is buried in the QRS complex. And I have a whole section in my advanced course on ecgacademy.com on how to recognize where the P waves are. But anyway, in AV nodal reentry tachycardia, you generally don't see any P waves. But that's the thing. You can't just rely on 5 or 6 seconds, because now what I want to show you is what happened after the patient sat down for a little bit. I have another strip here. And so after they sat down for a little bit, you can see that they're still going at about 165 beats a minute, and it's very regular and it's narrow, and a lot of people would still consider this to be PSVT, except for one thing, and this is where looking at the minor details, little fine details, kind of made me wonder, I don't know if this is AV nodal reentry. And the reason is it's just a little bit irregular. If you look at these first couple of beats, it looks a little bit faster than some of these others. And then here, I noticed on this T wave, it almost looks like a double bump. And then the next T wave is really quite smooth. And here again, you have another double bump, and then the rest of them are smooth. So, and this R-to-R interval seems a little bit shorter than the rest, and I can see it with my eyes. I can prove it to you with calipers. It's really not that important. But when you have AV nodal reentry or AV reentry, generally you'll see perfectly regular, like a clock, Now, there are exceptions to the rule, and there are actually 3 different kinds of AV nodal reentry depending upon which direction the circuit is going in. But for the usual variety, the common form, what's also known as slow-fast, going down the slow and up the fast pathway, it's generally regular like a clock. So I was like, let's see what happens in a minute or two. And sure enough, with the patient sitting down, after a minute or two, the heart rate began to slow. And then we began to see the real truth here. Now, it's very clear to see that there is a P wave that's separate and distinct from the T wave. And the other thing that's important is it's upright in the inferior leads. Now, that's the thing. When the AV node is part of the circuit, whether it be AV nodal reentry or whether it be AV reentry, the atrial signal is coming up from an accessory pathway or from the fast pathway. And so the atrial depolarization goes away from the feet. So you'll generally see negative P waves, which are known as retrograde P waves, when you have an AV nodal dependent arrhythmia. But these P waves are upright. So you have your diagnosis now. It's an atrial tachycardia. And it's because it's coming from the top of the atrium and it's heading towards the feet because it's upright in the inferior leads. And the other thing is it's beginning to slow down. And then it gradually slowed down and slowed down more and more until finally this last strip over here, if I can pull it up. Okay. Here. It slowed down to the point where it's about 120 beats per minute right here in the beginning of this strip, and then suddenly it went away. And the patient was back in a sinus rhythm at about 60 or 70 beats a minute. So it looks like there was an automatic focus in the atrium, may have been triggered by the adrenaline that's released during the stress test. So it starts to fire, and those first few beats, probably, if I had to guess, those first few beats were maybe an automatic focus. It could have been from anywhere in the high rate atrium or any place, but that could trigger an atrial tachycardia, and sometimes it could be reentry, or sometimes it can actually, a rapid beat like this can trigger that calcium-dependent triggered activity, those delayed after depolarizations. I see that all the time. And then as the adrenaline comes down and as the problem improves, it slows down gradually and then it'll break. So if I had to guess, I would say this could be a triggered focus in the atrium. The AV node is a bystander. And you have to kind of understand the mechanism, because how do we treat this patient? Well, a lot of cardiologists would say, well, it's exercise induced. It seemed the adrenaline probably caused this to occur, so we'll just use a beta blocker, right? So beta blockers are helpful when you have an arrhythmia that's moderated or triggered by adrenaline. Because what do beta blockers do? They block the adrenaline receptors. They block adrenergic sympathetic receptors. That might not get to the root of the problem, but it might suppress the symptoms. Except beta blockers often have a lot of side effects, so to leave somebody on a beta blocker long term just to suppress this, which obviously is not a serious problem. Supraventricular tachycardia is not life-threatening or anything, but you do have to consider the patient's quality of life, their symptoms, and you want to try to make them feel better. So a beta blocker might work, and it might be something that most cardiologists would try. But the other thing is verapamil might be just as effective, because verapamil affects that triggered activity. And verapamil is sometimes better tolerated than beta blockers in general. So that might be something that you can try. And would it be worth doing another treadmill test? Possibly, if the patient was really complaining about it. But if they were having a lot of palpitations, a lot of patients would just take the pill, and then you ask them, how you doing? You feel better? Have the palpitations stopped? And you could use that sort of clinical response as a gauge that your pill's actually working. That's a lot more helpful when somebody says, yeah, every time I do something it happens, and then it stops happening. Now, as far as nomenclature is concerned, since this is an ectopic atrial tachycardia that's firing, and it's slowed down, so there's kind of like a cool down phenomenon, that's why I think it's a focus and not reentry. Because atrial reentry circuits tend to be very regular, and they just generally just break all of a sudden. They don't slow down like this one did. So that's why I think this was a focal ectopic focus that could have been automatic or could be triggered. But my point is, if you're going to give this a label, you could call it PAT, which is paroxysmal atrial tachycardia, since it is atrial tachycardia after all, and it does start and stop. So it meets the definition. But don't fall into the trap of calling all PSVT PAT. PAT is kind of an old-fashioned term, and if you're going to use that term, only use it for the specific atrial tachycardia where the AV node is not part of the circuit. Otherwise, PSVT is a more appropriate name for it. So, so I do have a couple of questions, which is really cool. One of our listeners is asking, how would we differentiate between AVRT and AVNRT? Well, that's a good question, and it's hard to differentiate just based on the ECG, but the P-wave timing does help. Now, generally, if the A's and the V's are right on top of each other, it's almost always AV nodal reentry tachycardia. And that's the typical form, which is down the slow pathway and back up the fast pathway. So what happens is you get the retrograde P wave that's occurring simultaneously with the His-Purkinje system activation. So they're both happening at the same time, and so your A's and V's are kind of on top of each other. That's why you don't see P waves, because they're buried in the QRS. Sometimes they can peek out a little bit from behind the QRS, but for the most part, if you see that, then it cannot be AVRT, because with AVRT, you have an accessory pathway. So the ventricle has to depolarize before the signal can get to the accessory pathway and go back up again. So there, the VA time from the beginning of the QRS to the beginning of the retrograde P wave is more than 80 milliseconds. Usually the P wave occurs after the QRS is finished. You have the QRS, and then the retrograde P wave is seen. So AVRT, the usual form of orthodromic AV reentry tachycardia, you have a P wave that occurs after the QRS is finished, at least 80 milliseconds after the beginning of the QRS. Okay, now we're getting a little technical, because there are other kinds of AV nodal reentry tachycardia. There's fast slow, which is going down the fast pathway and up the slow pathway. There what you'll see is a retrograde P wave in front of the QRS complex with a relatively short PR and a long RP. And then you can have slow AV nodal reentry, where the retrograde P wave is kind of in between the two QRS complexes. So it gets really complicated. But as I said, I do go over this in great detail in the advanced course. I have a whole section on AV nodal reentry, which is kind of cool. I show you EP tracings and, kind of what we look for in an EP lab. Because obviously electrophysiologic testing is the only way to know for sure what you're dealing with. Could you have 3 different tachycardias in one patient? Sure, anything's possible. You probably started with an ectopic focus. It could have even been from a pulmonary vein focus. It could have been from the crista terminalis, which is the ridge in the right atrium, which is a common spot where arrhythmias arise from. But probably one rapid tachycardia triggered the other one to occur. So, all sorts of things can happen. So what was her treatment? Well, I just saw this in my office about a week ago. So that's why I'm sharing it with you, because I kind of saw it and I was like, wow, this is really cool. It looked like AV nodal reentry, but it turns out that it was atrial tachycardia. So with this patient, it kind of depends on how often they're having the problem, how bad their symptoms are. Sometimes, as I like to tell people, you can be creative with your medications. For example, let's say she was on amlodipine for hypertension. Well, you can easily just switch her to verapamil, and you can treat the hypertension with that calcium blocker, and you can treat the arrhythmia at the same time. So you can be creative with medical therapy, but in reality, if someone is having frequent episodes or they don't tolerate them well, or it's a young person who doesn't want to be on medications all the time, this is something that you probably could map and ablate, although ectopic atrial foci are a lot more challenging than AV nodal dependent arrhythmias. Why? Because AV nodal reentry tachycardia, you're looking for that slow pathway and you kind of know where to find it. And in AVRT, when you have an accessory pathway, it's relatively easy to map the AV groove because it's going to be somewhere along that ring. But ectopic atrial tachycardias, it's like looking for a needle in a haystack. Now, based on the P-wave morphology, this is probably coming from the high rate atrium, maybe the crista terminalis for you EP guys out there. And the crista terminalis is a very common spot for rapid atrial arrhythmias to arise from. So, that's probably a high likelihood it's there, but it could even be arising from the right superior pulmonary vein, which is less likely because usually pulmonary veins give rise to much more rapid atrial arrhythmias like AFib and flutter and so forth. But it's possible, but it's coming from up there someplace. And you could go in there. The difficult part is trying to induce it. When the patient's lying flat and they can't exercise, you can run in some isoproterenol or something else to get this to happen. And sometimes if you rapidly pace, like that burst of atrial arrhythmia, you might get it to occur. And then you could try to map it, but sometimes they'll break and it's very challenging. But it's doable. Definitely an ablation is feasible in this case. Do I need 3D mapping? Well, it definitely helps. In an ablation procedure, 3D mapping is a revolution. I always tell people that the ablation business, it's like there's a revolution every 5 years or so. When 3D mapping came out, it was fantastic because now you really kind of know where your catheter is in three-dimensional space instead of relying on a fluoroscopic image. 5 or 6 years ago, now we have contact force catheters. Now we know how much force we're applying when we burn, so we know we're making a good lesion. And then there was cryo. Cryo came out for AFib ablation, and so we have that. That was like 10 years ago. There's kind of like interesting stuff coming out. Pulsed electrical fields now is reported to be very effective in ablating pulmonary veins. So I would say, every 5 or 10 years there's a revolution in the ablation business, but definitely 3D mapping is very, very important. It's once you use it, you'll never go back to the usual 2D catheter mapping. So I really do appreciate all the interest and the questions. We've been going on for a while, and let me see, one last question regarding ECG Academy. When will some of the topics that are not yet covered, mechanism, ventricular arrhythmias? Well, that's a really good question. I've had a lot of people kind of email me and say, hey, Dr. Nick, when are you going to get the rest of the advanced topics up there? And I have every intention of doing it soon, because I want to be able to fill those gaps in and offer you guys like the best ECG training that you can find. I guess the problem is I'm offering the academy to schools. I have my medical practice that I have to contend with. We were doing these live streams, so there's always seems to be something else to do. And would you believe that it takes me about 4 hours to produce a 15-minute advanced video? So it really is a big time commitment. And I'm not trying to make excuses. I do apologize that I've been promising this for a couple of years now, and I definitely have every intention of working on it. So I appreciate your support, all of you out there. If you are part of ECG Academy, I thank you kindly. If you enjoy this kind of content, please support me by spreading the word. Let your colleagues know about this YouTube channel as well as ECG Academy. I think I try to explain arrhythmias in an easy to understand fashion and get internal medicine people and cardiology people to think like an electrophysiologist. And for EP fellows, I hope I can give you some insight into my 30 years of experience. But this is a new field. This whole education thing and the live streaming is kind of new. So it's exciting and I appreciate it. And thank you, all of you, for watching. And those of you who watch it afterwards, thanks for your support. And as I said, if you want to check out ecgacademy.com, it's a great place to learn more about the reading electrocardiograms like an EP doctor would do. I mean, you want to become an expert. I like to say it's like looking at ECGs in a whole new light. So until next time, this is Dr. Nick Tulo. Thanks for watching and have a wonderful week. Now I have to turn it off.